Yeah, I can manage people coming in. You want to
Great,
start,
thanks,
Katie?
Emma. So, wow, hi everyone. It's so amazing to honestly see so many of you. We really didn't expect such an amazing turnout, so we're really grateful for all of you that signed up and are attending today. Um, and welcome to our webinar. We will tell you it's going to last for an hour and a half. And it's about building trauma-informed assessment practices with the Your Story project. As you all know, this meeting will be recorded, and Emma's already said, feel free to introduce yourselves in the chat. Emma, did you want to do a bit of housekeeping?
Yeah, just some housekeeping. So yeah, while me and Katie are speaking, it'd be great if everyone could keep themselves muted. I think there's an option where we can do it for you, so that shouldn't be a problem. And there will be a Q&A at the end to allow time for questions. So if you have any questions while we're speaking, please feel free to use the chat and we can come back to them at the end. And just to let you know, there may be some conversations that happen that might be challenging or difficult. So if you do need to take breaks, that's absolutely fine. And look after yourselves. And Katie and I will stay around at the end. If anyone wants to talk to us just privately, then that's absolutely okay.
Lovely, thanks, Emma. So today there will be four of us taking you through the webinar. My name is Katie and I work for Changing Futures Plymouth. I've worked in the housing and homelessness sector since 2017, but more recently, in the last couple of years, I've joined the Changing Futures team to work more widely on the kind of system change side of things. And I'll hand over to Emma so she can introduce herself.
And my name's Emma, and I've been working for the Changing Futures programme since the end of 2022. And yeah, I've been supporting Katie with the Your Story project. And then we've got Rowan and Amber who will introduce themselves when they come on speaking a bit later. We're delighted to have her with us as well.
Great. Thanks, Emma. So to give you a bit of an overview, what we're going to cover today, we'll give you some background about the Your Story approach. We'll tell you what it is, and we'll talk a little bit about the aims for culture change and how it's based off lived experience and what we've heard from people who use services in Plymouth. We will tell you a little bit about the purpose of the tool, what it is and how it can be used. We'll share some early feedback from the pilot. We will hear from practitioners in this field, Amber and Rowan. We can give you some suggestions on how the tool that we've created can be embedded in the services. We'll touch a little bit on the system conditions and then we'll have some time for the Q&A. I'm not sure if you know a lot about Changing Futures, but Changing Futures Plymouth is a government-funded initiative aiming to improve outcomes for people who experience multiple disadvantage. This is a lovely infographic created by one of our peer researchers, Hattie. I think it gives a really nice overview of some of the things that we cover as a program. Granted, it does need to be updated a little bit because we've now changed and it's now MHCLG, not DLUC. But we're always really excited to share this infographic because Hattie's just done an absolutely fantastic job. And before we go ahead any further into the project, we just wanted to make it very clear that this is a pilot. And we are still learning. We're really excited to share our learning with you. But just so you're aware, we might not have all the answers for you, and we are still on our journey to find them. But there's, plenty of things we can do differently. We know that one approach won't fit everybody. So yeah, we just wanted you to know that this is a test and learn project, and we're excited to share this learning with you. So a little bit about our values as a program. Our main objective is for people who have experience of multiple disadvantage to get the support and opportunities that matter. at a time and a place that matters. And we believe that culture is key to any system change. All of our work, we aim for it to be co-produced. We're, passionate about trauma-informed practice. We focus on prevention. So in this case, we want to prevent people from re-traumatisation, from having to repeat their story. And alliance ethos, we believe that Plymouth is working better, or is working better as an alliance. So what do good principles look like? We really like the principles developed by Changing Futures Northumbria, and they call it the liberated method. So in their approach, they use 2 rules and 5 principles that practitioners use to guide them through the work with people who have experience of multiple disadvantage. And we really, really like that approach, and we've decided to use these principles to underpin our project. And their 2 rules are stay legal and do no harm, and the 5 principles are understand, not assess, and we will refer to that principles quite a lot throughout the webinar. Person sets the scope, decisions made in the work, and we pull for help. We don't refer people and close. Apologies about that. And there is no time limit. It takes as long as it takes. So what's the Your Story project? Kind of the overarching aim of our project is to promote culture change within assessment practice, where ways of working between individuals and services are more relational, human, power balanced, and trauma informed. So what are we doing? We are developing an approach to enable people to take control of their information when using services. We want to empower people to share their story in a way that matters to them. And by doing that, we hope to reduce the need for people to repeat their story and risk re-traumatisation. And why are we doing that? We're doing that to shift the power dynamic. We're doing that to rebuild the trust, to show people that they've said and we did it, to show that we've listened. We're doing that to improve outcomes for people who experience multiple disadvantage. And we hope that by doing that, we will create a better environment for practitioners. And by doing that, we'll improve staff retention and satisfaction. How are we doing that? We're developing a tool alongside people with lived experience of this issue. We're working with organisations to promote Your Story approach, and we're also embedding the team around me model. So what's the vision for the project? The kind of end goal, the vision, we suppose, is for assessments to be person-centred. And as Dr. Karen Treisman says, she's the leading expert in trauma-informed practice, every moment and every interaction can be an intervention. So let's try and maybe move away from just focusing on completing forms, and instead of using assessment time to really get to know the person and provide meaningful support. So we hope to go from something that currently looks a little bit like this. This is what people have told us, that that's how they experience assessments. People feel like they have to repeat their stories. There's a power imbalance in the room when they undergo assessments. Sometimes when they're stressed, people forget important details. They worry, will they pass the assessment, or, will they meet the criteria? Can they trust the person that is assessing them? And sometimes, sometimes people just complete forms because they have to follow policy. And there's a lovely quote from one of the people that took part in the pilot. And the trauma has just impacted on everything I do. And it's too painful to explain it again to everybody. It's just too painful. And if I don't explain it, then they don't know where I'm coming from, and then they call me irrational. So we hope to go from something like this, using an intervention that kind of looks like this. So before an assessment, a practitioner can say, do you have anything you'd like to share with me before an assessment to help me get to know you? If so, my email is, or you could encourage somebody to bring that story to their assessment. And the person says, oh, I didn't know I could do that. I will send you my story before we meet because I tend to forget important details when I'm stressed, and maybe deep down they're thinking I'm a victim of domestic violence and a man's presence triggers me. Or they might be thinking, I don't really like to meet in busy places. So by providing that information before the assessment, the practitioner can use that to kind of adapt their way of working and provide a safer environment. So just to recap, we want to go from something that currently looks like this, using this, to this. That's the kind of end goal. We want assessments to, during assessments, we want people to feel like the power is shared. There will be a reduced risk of re-traumatisation. People would be feeling heard and empowered. We could create more psychologically informed environments for people and relational practice. And instead of kind of focusing on the form, we could have meaningful conversations and support with people. And again, this is just some lovely feedback we've had from one of our participants that, when she undergoes the assessment, she wants to, please give me as much control as possible so that I can feel powerful in this situation. And again, that takes us really nicely to one of the principles that we discussed at the beginning, that we want to understand people and not assess them. And I will now hand over to Emma, who will tell you a little bit about the background of your story project.
Thanks, Katie. So I'll just give a quick overview of the background and also the co-production groups that took place last year. So it's been a long-standing systemic issue of the people having to repeat their stories to services and the re-traumatising impact that this can have. And this was indicated in community research and appreciative inquiry prior to the Changing Futures Plymouth programme. And then when the Changing Futures funding came to Plymouth in 2022, this was a real opportunity to explore this issue and see if there was any way that we could use our resources to approach this and make assessment practices more relational and trauma-informed for people, and really give ownership to people when they share their story to services. So the Passport Project started, and we spoke to different organisations and areas around the UK that had adopted a passport model as an information sharing tool. We also hosted a workshop back in 2023. And if you just go to the next slide, Katie. We had a workshop with people with lived and learned experience of the issue, and a few themes came out of that workshop of how people wanted, what was the vision for how assessments could take place or information sharing to take place. And two of the key themes that came out was the person to own the data and how it's shared, and humanising. So this formed the basis of the Passport Project. And so the action group was set up, which is a group made up of people with lived and learned experience of services and assessments. There's probably a few members in this call today. And they have really been the driving force behind co-producing the passport tool and the various activities that have taken us to where we are today. So one of those was cross-referencing different referral and assessment forms around the city and different services that support people experiencing multiple disadvantage to find out what was frequently being asked in assessments. And it was discovered that a lot of the time it is the same questions being asked. And so the first draft version of a tool was created based on these questions. And we then needed to do a further call out for people with lived experience of repeating their stories to services to join us in co-production groups where we could go through the tool and adapt it, hear people's thoughts, change the questions. What did people want services to know when they come in for an appointment? So a mix of in-person and online focus groups took place with people with lived experience. And shortly after this, Katie met with members of the housing teams in Plymouth City Council to understand why questions were being asked in assessments, because a big thing that came out of the focus groups was that people wanted to know why they were being asked things, and they wanted to know the reasoning of why they had to be vulnerable and share things about themselves. So after the co-production groups, the findings were consolidated and the tool was adapted. And one change that took place was that it was now renamed to Your Story, which based upon suggestions which came up in the group. And the vision for the culture change was established. And then fast forward to today, the tool is now being tested by individuals, mainly those from the original co-production groups, which is lovely. And we're adapting the tool as we learn. So that's just the poster that Katie designed, which was the call out for people who wanted to be part of the co-production groups and co-designing the tool. And we had 40 people in total reach out from that poster, which was amazing. And I think goes to show how widespread and passionate people felt about the project. And these are just some of the quotes that came up when people were doing their expression of interest to join the group. I think a particularly powerful one there is yes, it's exhausting and makes me feel invisible. And yeah, to the left is just one of the information sheets that we gave people before the co-production groups. And Katie will come in just to talk about this learning that we had in one of the groups.
Thanks, Emma. So in one of my previous roles, one of my responsibilities was to complete assessments with people. And what's your local connection was one of those questions in the assessment. And I must have asked this question dozens or maybe even hundreds of times, and it never really occurred to me like why why we're asking the question. And it wasn't until I sat down in the focus groups with people who have lived experience of accessing services in Plymouth that they said that they felt really uncomfortable about this question, because in the past they felt like they were being they're looking to exclude me because they haven't got a strong enough connection to the city. And that's been personally that's been a huge piece of learning for me, because it never occurred to me why I've been asking people that question when I was assessing them. So yeah, really, really interesting bit of learning, and collectively we've decided to remove that question from the passport. Thanks, Emma. I'll hand over.
Yeah, so just touching upon some of the what came out of those co-production groups, we've got loads of quotes and themes that were emerging. One individual in particular was particularly passionate about this project, and she has given us full consent for her to use quotes from her, as she actually wanted us to make a passport for her there and then in the session, so that she could use it straight away when accessing services. So if you just jump to the next slide. So a quote from her is, when I get the same story, I will send you to social prescribing. I think I've been through that 3 times already. They don't do befriending counselling. They do signposting, which means you get 6 half-hour phone calls where they tell you to go somewhere else. And then when you get to the somewhere else, they tell you to go somewhere else. And then when you get to the somewhere else, they sign you right back where you started in the first place. And at the end of this, you're absolutely exhausted. You've kept about 50 people in work, but nothing has happened that's helping you. It's really good because it stops people repeating efforts that other people have made, because all the people I'm signposted to, you blissfully believe that there is somebody else out there who is doing the work, and there isn't. So that was a particularly powerful quote, and she shared her story of us and her experience using services in Plymouth. Just go to the next slide. Yeah, there was a range of learnings that came out of those groups, which we can share you the full document with all of that after this call. So I'll just touch upon a few of them. So there was feelings of people being passed around, people feeling that assessments were intrusive, and people not having trust in why they were being asked questions. So there's some quotes along there. We've got mentions of racism and being neurodiverse. So the first one says, I'm stunned that every time I go for an assessment, and I've now been assessed by nearly everyone that exists, none of which has ever led to any therapy or any help. By the way, it's been an exercise in frustration, rage. Not once has anybody asked me, do you sleep? So I'll just give you a second to read those other quotes if you like. And yes, Katie and I can share with you the full findings from the groups that we had that were in person and online. And I'll pass over to Katie, who will talk a bit about how the tool has developed to where it is now. Thanks, Katie.
Thanks, Emma. So, as Emma has kind of described the story so far, how we got to where we are, we had to develop a tool. And for complete transparency, the project did stagnate for a couple of months because we couldn't find a solution that was easily accessible for everyone. We looked at various apps, however, they were expensive, and we weren't sure if it's worth kind of investing a lot of money in an app when we weren't sure if people are going to use it. So we came up with a really kind of creative way to create a tool. And what we've done is we've used Microsoft Forms and Power Automation. Is everyone okay? Can everyone see the slides? Okay, lovely. I've just seen a message.
Claire, if we just maybe try leaving the call and then joining back in. If not, we can send you all the slides afterwards.
Okay, lovely. Yeah, so we decided to use tools that are free and easily available to people who work in different organizations. So I'm sure many of you have either completed a Microsoft form before, and some of you maybe even created your own forms. It's a free tool as part of the Microsoft 365 suite. So is Power Automation. I'm not sure if many of you are aware of the Power Automation, but essentially what we've done is we've combined the two, and we've set up a very simple process that every time a person completes your story, every time a person completes their story, they receive an automated email with all of their kind of information. We decided to add a little bit of pizzazz to our project, and we've set up a new separate email address. So we now have yourstory@plymouth.gov.uk. So whenever people do complete their stories, it does actually say, received from yourstory@plymouth.gov.uk. And here is a little screen grab to show how it kind of shows when people receive it. And I'm sure many of you want to see the tool and what it looks like now. And yes, we will show you some pictures and some questions that we've included in the tool or the tools. But before we go ahead, I just want you to pay attention to the language that we've used, because as we all know, words do have power, and the kind of language that we use is very important in trauma-informed practice. So we had some really good feedback about the kind of what matters to me questions, because people said it's given some kind of connectivity. And, when we've included phrases like people, please feel free to elaborate, people felt like you cut through for that individual. They've been able to ignore the issues that aren't theirs and only focus on the issues that are theirs. So I'll quickly take you through the tools. We have two versions of the tool. We have the short version, which is it only consists of 4 questions, and people just have the opportunity to say what happened to you, how did it affect you, and what support do you need now? And this one, really, really interesting. People wanted to have a space where they can tell the assessor what would you like people to know before they meet you. So if you remember right at the very beginning, we said about the vision, and this is a space for people to say, this is what triggers me. Maybe I don't like physical contact, or, I prefer to be in a neutral place. And by sharing that before the assessment, and enables the practitioner to really kind of take into account how, when they do conduct the assessment and when they meet for a support session, how they can create a psychologically informed environment, a safe space for that person. Some other questions that we've included: current address or housing situation. And here you can see that we've provided explanations like why it might be helpful to include that information. That's the long version. So we have two versions. Short version is only 4 questions, and the long version is kind of more in depth, and people referred to that version as the scaffolding information. So again, do you have any children or caring responsibilities, and why it might be helpful to include that? If you have any communication needs, and some prompts what that might be. Again, the what matters to you, what's your story, what do you need? These questions had really good feedback. And please note the language that we've used. In this section, you can share details about yourself, about your story. This is a space for you to show who you are beyond the standard referrals or assessment form. You can, but you don't have to. And again, one of the questions, well, one of the quotes we've had is people said that when they undergo assessments, nobody really asked them, when's the last time you ate a nutritious meal, or what's your sleep like? So when people said, if you're feeling ready for change, please use the space below. Again, these are some really difficult questions that sometimes we have to ask, but there might be some better ways in which we can ask them. This one, for example, refers to drug or alcohol dependency. Remember, this is completely optional. Be kind to yourself, because we know that these questions and these experiences can bring about feelings of shame. This was a really exciting suggestion. If you did spend time in prison, you can use the space to share any new skills or qualifications that you gained in any work or any work experience. And some feedback so far. So we've got a few people now trialing the tool, and that's the feedback we've had. People said it's a really good form in that it captures essential data, but needs more work for more complex stories, or the capability to upload extra support and evidence for those that need to add extra information. People said, so long version, I love it. It feels very therapeutic. The date of birth doesn't let me go easily back to 1978. Somebody said it was an exciting experience that I can give out information about who I am without having to repeat myself. I felt it made a difference in the support I received from GP, and I feel it will be very helpful in the future. There were loads of details in the form that the GP saw that I never told anyone. And again, some more feedback. Somebody said, really appropriate for a quick update or introduction to the service, would really help to be able to upload attachments. Plus, it would help to know the character limit on the boxes, as my story is very complicated, but a workaround could be to be able to add attachments. But just to take us right back kind of to the very beginning, the tool is just a tool. Our focus is on the culture change and how we can change our assessment practice. We've designed a tool to help people along this journey. But yeah, it's less about the tool and more about the culture change. And I will share a little bit about data sharing. So at the moment, what people have told us that things look a little bit like this, that it's kind of, you have long waiting lists, people are allocated, we have to complete forms, close people, sort, pass on. And we really want to, move from this experience to just simple understanding, planning, doing with people, reviewing with people. So really person-centered approach. So that's the goal. In terms of, again, data sharing, people can indicate a preference in the tool. of what they want. If they decide to share your story with an individual or an organization, they can say, I do not wish, or I wish for my story to be shared, but please ask me prior to sharing, or no, just go ahead, share it with whoever you want. But please note the word preference, because it might not always be possible to kind of stick to the person's original wishes, but I'll touch a little bit on that in a minute. And again, data share in the end, thank you for completing your story. We want to acknowledge we want to acknowledge the value of somebody's story. We've given people suggestions on how they can share that with organizations before assessments, or alongside, they can share it with their GP. So just some suggestions on how that might be helpful. So as it works now, we have the link to your story. We've created our own inbox for that. But if people wanted to implement it, it would be like the trusted professional holding the link to your story, and the trusted professional or the trusted organization would be responsible for keeping the information safe and sharing it if the person requested for the information to be shared. And you note that I mentioned the word preference earlier. People can indicate the preference. However, there are some situations where, we might have to break confidentiality. And we know that the law does not prevent of sharing sensitive personal information within organizations, or, between organizations. So where a serious crime might be prevented, or there's a safeguarding concern, sharing it may be justified. Whilst it is good practice to gain the person's consent before sharing the information, it's not always the case. So again, it can indicate the preference, but it would be within everybody's responsibility to stick to their organizational policies, procedures, and the law. And when it comes to data sharing as well, it kind of works both ways. Like, we're not just extracting information from people. We're asking, is there, maybe we can shift to, do you have anything you'd like to share with me? So that we can shift the power dynamic, and we can again move towards that understanding somebody and not assessing. We can also ask them if they haven't got a story that they share with us. We could say, would you like a copy of this document for your records, or the assessment that you've done together, to acknowledge the value of one story, and to kind of show them that we're not just extracting the information, that we can share that. And again, within everybody's responsibility to inform about confidentiality and safeguarding. So we wanted to kind of delve a little bit deeper into the data we're collecting, and try and understand maybe what questions are we asking. So we know that this is how people are experiencing assessments at the moment. So instead of maybe asking questions that don't help you understand a person in their own context, we can shift to kind of questions that do help you understand, maybe more open questions, instead of asking insensitive questions that might trigger somebody. We can, or irrelevant or deficit-based questions, we can shift towards asking strength-based, person-centered questions, and kind of, being mindful about our language. Again, there's a lovely quote at the bottom from one of our participants. And how are we asking? So instead of maybe during assessments, instead of asking closed questions, or instead of the assessor always completing the form, sometimes, being unaware of their body language. So looking at the form instead of at the person, or, just looking into space. Sometimes we rush through assessments and the questions because we need to fit in the allocated appointment time. We can shift to people having choice over how they communicate their information. We can shift to giving people options to fill out the form together with a trusted professional. Shifting to starting assessments with kindness and like a genuine interest in the person, first asking the person, how are you, and mean it. And again, note the understanding, not assessing. How are we asking? Are we using shame-sensitive language? Are we mindful of our body language? And again, this is just a really powerful quote from another participant. Because all the way through the NHS, there is this massive power imbalance that's very obvious to the client, and blissfully, the people who aren't the clients are actually very, very unaware of it. Some things like your chair being the same height, saying hello, how are you, and introducing yourself, how to act like a human being towards another human being. And when are we asking? Do we ask ourselves, are we asking difficult questions as soon as somebody walks into a service? Are we asking questions when somebody's distressed, not ready to answer them? Are they, within the window of tolerance? Are we paying attention to that? We can shift to asking the hard questions once we've built some relationships and trust with that person, and asking the questions at a time and a place that they feel comfortable. Again, a lovely quote from one of our participants. I think when you meet someone, you'll definitely know if you can continue an open-ended question with that person or not. Sometimes you just know if you click with a person, and if you feel like you can trust them. And it's really difficult when you're feeling vulnerable, when you're going for a tough time, and you have to open up to somebody. Like, how do you know you can trust them? So again, just something to kind of keep in the back of your mind. And why are we asking? Really, are we aware of kind of the purpose of the questions we're asking? Are we collecting maybe sometimes irrelevant information because it's on the form, because that's what the policy says to do so? Is there little or no explanation in assessment forms? Why is this information requested? Maybe we can shift to asking questions that help us really understand a person in their own context and give really clear verbal explanation of why we're asking this question, how it might help them, where the information will go. And again, the example that we've given is when somebody said they feel really uncomfortable about asking what's the local connection, what's the local connection to the city. They felt suspicious about it. They felt like that it was there to catch them out. So yeah, just when we think about collecting some information, what, why, how, and when. And I will hand over to Emma now, who will take us through some of the system conditions.
Thanks, Katie. So, yeah, with these system conditions, we wanted to acknowledge that this approach won't solve everything. I mean, the tool won't solve everything. We hope that the tool will promote an approach which is better for both practitioners and people using services. I think this quote here from one of the participants of the co-production groups sums up the difficulty of having one assessment style that will suit everybody. I'll just give you a second to read that. And it also alludes to the
Sorry,
time
Rowan said, can
constraints
we
as well.
read it out?
Oh, of course.
To say.
Sorry. Oh, yeah, some people can't see the slides. So can you understand how difficult it would be for anybody to design a form that takes into account what's happened to me, but also takes into account who somebody who was in Iraq and saw their friends getting blown up, or somebody who's gone through a really horrible divorce, or somebody who was beaten up by their husband? So to me, there are only two important questions on the form. What happened to you? And you could hear a story of homelessness. I'm a man, my wife divorced me, she ran off with someone else, and now I can't afford a home because my other money payments are crippling me and I'm living in a dumpster. I also don't get to see my children, who I love, because I'm now homeless and the wife has custody. So I've done nothing wrong, but I've lost my job, my family, and my home. How do you design a form? What happened to you? And if you can condense that into 5 or maybe even 10 bullet points, or even fewer, because remember, the person reading this has got all of 60 seconds, 10-minute GP appointment, a 20-minute cancer appointment. They do not have time. So I think it's, if you just swap to the next slide, Katie, I think it's important. Thank you. I think it's important to be honest about the harsh conditions that people are working in, and recognizing that there are some more deeper structural issues that are more difficult to get around, but we hope we're still learning about how this approach can support people at work and how it can not sorry, I haven't got the words, but instead of creating more work for someone working in services, it will hopefully create more time for people to do the work that matters for people. There's just a few there on the screen.
And if you can think of any system conditions, feel free to pop them in the chat. Do you want me to move to the next slide, Emma?
Yes, please. And also wanted to raise that a big thing that came out of the co-production groups was the appreciation for staff and how it's amazing individual staff working in a difficult system. So there's just quite a nice quote here from somebody who said, "I know the staff out there that are doing really hard-working jobs, working hard, doing their best. I'm accessing them because of the barriers of the referral process. Assessment process is nigh on impossible at times because the system is so stretched, and I think it's because it doesn't have the frameworks and the forms and the paperwork to support everybody. I could go on and talk for hours and hours about this, I'm afraid, because I've seen both sides of the system. I desperately think it's horrific at the moment. I feel for staff working in it because I know they want to help people who they really do, and they're genuine, but they're backing the heads off the wall at the other end because the form they've got or the paperwork that they've got doesn't match what they need to give the client or the legislation." So what's next for the tool? So at the moment we're trialing, so some individuals are trialing the tool with services, and we're in the very early stages of that with people providing feedback, and we're changing things as we go, as we learn how this approach can actually work in practice, because obviously we are going to run into hurdles, but we're hoping we can learn together and try and find an approach that works the best for both people using services and the people working in services. And then we hope to trial the approach within organizations or teams, so where they'd actually hold the link to the Microsoft form so that they can view the responses of the person they're supporting. And then we have plans to do appreciative inquiry with practitioners who are maybe trying to embed this approach, and then we'll keep reviewing and sharing learning and measure the impact of the intervention. And we will also build a toolkit which sort of encapsulates all of what we're discussing today and how to practically apply it.
Thanks, Emma.
Katie.
So how easy is it to embed this approach? We came up with a few suggestions what might work for you. Again, it's less about the tool and more about kind of changing our assessment practices. So if if you're interested in partially implementing this approach, for example, if you only wanted to find out what your service users think of your assessment forms, great. We can provide you with the guidance for how we've structured our focus groups, some posters that we've made, and some email templates just so you can kind of adapt it. And we can, share some good co-production guidelines with you and maybe even support with facilitating some sessions. We can show you how, we've structured our findings document, how we've come up with the themes. So just to give you, a really good idea of how to maybe co-produce your own assessment forms. If you maybe wanted to give people the option to share their stories with you before you meet, great. We can offer regular sessions to support you through that process. We can offer some trauma-informed training. Maybe you're thinking about it, but you're not ready. That's okay. We can provide you with some really useful resources about trauma-informed practice. And we can send any relevant training opportunities and other ways to get involved. What about maybe like full implementation? You want to use the approach and the tool exactly as it is. Great, we can make the necessary changes for you and share the templates with you. If you only want to do focus groups and create your own tool, will you help me? Of course, yes, we will help you. Again, we can offer regular meetings to assist you in setting this up. Or what if you want to we've had a couple of these questions before. What if you want to replace the assessment form with the long version of your story tool, your story tool? What now? That's absolutely amazing. Again, we can offer some Changing Futures Project Officer time to help you to implement this. And what we've also done is we've done a bit of guidance on how easy it might be if you did like the template of how easy this might be to implement that on your system. We can quickly go through that, Emma. I think we do have a bit of time. Okay, so changing features, the first thing that we would have to do is I would go into kind of the forms that we've created and I would click share as a template. What I would also do is I would go to the flow and I would send you a copy of it. You would then receive it and you would have to accept the form and duplicate as template. And there is a video of like a little bit of a technical video. I'm hoping it will work, but if not, don't worry, we'll send the slides out. Can you see that okay? Is it working? Lovely.
I don't think it's working for us. It just says it's not currently.
Oh, it's just working for me. We will share it out afterwards then.
Oh, okay.
Sorry about that.
Okay, but yeah, the video is only 2 minutes long, and if you did want to implement it, we share the templates with you, and it's what, Emma, like 3 clicks of a button? It's relatively straightforward. Okay, and wow, we've actually made some really good time. We will hand over now to Amber.
Thank you, Emma and Katie. I'm not going to take up much time. I'm just going to sort of share a little bit about myself and the organisations that I'm working for and how we're hoping to be one of those organisations that is going to embed or implement the Your Story within our organisation. So I'm part of the Trauma Informed project. We're relatively new, it only commenced in January 2024. And our aim was to identify and showcase sort of best practice regarding trauma-informed care. So not only are we looking at what's happening in Devon, we're also looking at what's happening UK-wide. So really having a good understanding of what's going on in different areas, how they're offering trauma-informed care, and ideally how we can then potentially replicate that or develop that and use that within our systems within Devon. So geographical reasons, we are based out of North Devon District Hospital, which is part of the Royal Devon Hospital Trust. So we are doing an awful lot of work regarding NHS practice. So the bits that I'm going to be talking to you about this morning are more NHS based, but we are hoping and considering that Your Story, we can support other organisations to implement that across Devon as well. So a little bit of history regarding health passports, patient passports. They've got lots of different names regarding them. They have been supported by NHS England since 2015, although in that time they haven't actually created a health passport or a patient passport. That did change last year, so NHS England have created a template for a patient passport, but having looked at it, it isn't particularly trauma informed, and it might not necessarily support somebody to be able to talk about their trauma experience or their trauma history. So we were really excited when I came across Emma and Katie and the wonderful work that they are doing. I am also part of a national group that's sort of dedicated to exploring and addressing health passports or patient passports, especially with regards to a trauma-informed lens. And I know some of my peers are here this morning, so I'm really, really pleased that you were able to make this and see the amazing work that Emma and Katie have done. So when we were considering patient passports or health passports back in January of last year, we sort of had a look at what's already out there for the trust and thinking about Devon-wide. What we did find was that there are various types in circulation with regards to their utilisation, their overall impact. Our findings revealed that most of them were all paper-based, either completed by the patient on their own or by professionals. There were a couple that were created by both, but not necessarily in collaboration. We also noted that many of the questions that were included were quite irrelevant to the individual's needs and did not effectively help the patient or the individual articulate the ongoing impact of their trauma experience. So it's really, really important that we were to either create, develop, or find a tool that would be able to do this. So if we can just go to the next slide, please. I'm not sure, Emma, Katie, who's controlling the slides. Thank you. So this is what we are hoping that by introducing your story will do. So we have huge visions that this actually could be really, really impactful in many departments, many services, many areas across the trust. We are primarily focusing on the emergency department, and potentially there's a couple of other wards that we're looking at as well. But we know that, as Emma and Katie have shared within this presentation, that there are some huge, huge benefits from introducing your story. So the improved communication. So we know that we are looking at implementing the shorter version, so the 3 or 4 questions. So we know that's going to be providing a concise summary of somebody's trauma history. We know that that's going to help the healthcare providers communicate more effectively and sensitively with the patient. The personalised care, by knowing someone's trauma history, we're going to be able to tailor our approach to be able to meet someone's specific needs, and ensuring more effective and compassionate care. We're hoping that it increases patient satisfaction. So that's with their whole healthcare journey, their whole healthcare experience. We're hoping it reduces trauma activation, which is often or can be perceived quite negatively by others. We often hear of talk about disruptive behaviour when we know somebody's been activated. This also includes social withdrawal. So when we're thinking about missed appointments, or DNAs, is which we often call them in the health setting. So we're really hoping that hoping it's going to improve those. The Your Story Passport is also going to provide this sort of clear outline of what reasonable adjustments might be needed for somebody, so we're able to offer them the health response that they are needing at that time. We also believe it has the potential to reduce readmissions, thinking about the length of stay that somebody might be within an acute ward, for example, or by thinking about the amount of admissions they might have. So especially thinking about the ED, the accident and emergency, the emergency department. So we're hoping that by increasing the use of reasonable adjustments and enhancing the understanding of what somebody might need is going to be improving their sort of health pathways or their care pathways and their outcomes. So avoiding re-traumatisation is vital. So understanding somebody's trauma history, understanding what might activate somebody's trauma response. We're going to be in a position to avoid those actions. We're going to be in a position to potentially think about the environment in which we're seeing somebody, and sort of recognising behaviours or things that might inadvertently re-traumatise somebody. So thinking about maybe unnecessary physical examinations or the gender of the person that's carrying out any support. Thinking about asking what somebody might have to change into. So thinking about clothing, thinking about loud noises, all of those sorts of things. So what we're hoping also is that this approach is going to reduce the need for somebody to repeat their story, which we know many, many individuals accessing health are having to do on a regular basis. Building trust. So when individuals feel understood and supported, it's going to help us build trust between them and their healthcare practitioners, which is essential for effective treatment, thinking about patient cooperation. It's going to lead to improved outcomes for any encounter then with any health sort of service or others as well. So patients are more likely to sort of trust healthcare providers or staff or individuals who acknowledge and respect their trauma history. So this is enabling that better communication and cooperation. So we've sort of mentioned better health outcomes as well. The other thing that I think is really important, and this is something that we've spoken about at quite length It's the efficient use of resources. So there is a little bit of a challenge that staff may feel that this is going to increase their workload. It is going to increase the amount of time they might need to spend with somebody. It's sort of understanding that, is that their part of their role? Is this something that they should be doing? What we're actually recognizing is, if we can get this right at the beginning, if we can be asking these questions in this particular way, if we can be understanding somebody's situation, we're going to actually be able to streamline the care processes and health provision much more effectively, and that's going to hugely benefit not only the patient but also the staff that are working in that environment as well. It's potentially going to reduce the need for repeated assessments, interventions, and therefore making it more efficient use of resources. So my final slide, I did say this was a very quick introduction, is just sharing with you some of the key considerations that we've had for implementing Your Story in the emergency departments. So I do know that we have got a little bit of time later on for questions. So you may have certain questions as to how we're potentially going to be delivering this or using this within our areas. So simplicity and clarity. So as I said, for the emergency departments, we are looking at using the reduced version or the shortened version. And we do recognise it is concise. It's really easy to read. And that's making sure that the ED practitioners are able to really quickly grasp the essential information that's being shared from the person. Patient consent. This is an ongoing conversation that we are having. We feel very strongly that it's really important that this information needs to be held by the individual, not necessarily held by us as a healthcare system. What we don't want to do is assume ownership of this information and put it straight up onto health records where it might sit for years and years and years. What we want to do is to make sure that we are obtaining patient consent before we are sharing and uploading, and making sure we have that understanding of who it can be shared with and where it can be shared with. And ideally, what we want that consent is to always sit with the patient. So if something needs to be changed or amended or removed, then it can be done easily. So really respecting the patient's sort of privacy and autonomy regarding their story. Accessibility, so we want to make sure that Your Story are available in multiple formats. So thinking about large print, braille, translated versions and so on. We really want to make sure we're accommodating everybody with all their needs. We are looking at digital versions, thinking about how we can use that. We do know that many people do prefer electronic formats. So again, thinking about how we can use that within our system. Support for completion. So we want to make sure there is guidance and support for patients who may need help completing their Your Story. Thinking about how we can offer assistance from trained staff, potentially volunteers, using user-friendly instructions and guidance like Emma and Katie have completed. Staff training is really important. So we want to make sure that staff understand what Your Story is, need to understand how to interpret the information, how to respond when somebody shares this information with them as well. So that's going to be sort of in line with our offer of education around trauma-informed care principles, to be able to sort of understand, enhance understanding and empathy. So integration. So as we've said, whilst the information isn't going to be automatically uploaded onto our systems or onto the trust system, we currently have the trust system of Epic. We are considering how they can be integrated into somebody's sort of overall care plan or health package. So we want to make sure that there are really good processes in place for being able to share relevant information with consent. Feedback loop. So we are going to be working with Katie and Emma to establish a really good feedback mechanism where both patients and staff can provide input on the effectiveness, the usability of the passports, and be able to make contributions on improvements as well. And then we need to think about promotion and awareness. So how are we going to raise awareness of the availability and the benefits of your story. So again, not only among patients, but also thinking about staff, different departments, different wards, different services, and so on. So the use of posters, leaflets, digital communication, and so on. There are a number of ways we believe we can measure the effectiveness of your story. So thinking about the metrics of complaints that we receive, thinking about the patient advice liaison service and the cases that they are working with, so that's PALS, regarding often care delivery, thinking about patient satisfaction surveys. And we can also use the metrics of the missed appointments or did not attend rates as well, just to see the impact that your story is going to have on somebody being able to access health and do it in a trauma-informed way. So that was a very quick whistle-stop tour. I'm hoping that was quite helpful, and I am going to be here for the remainder of the webinar if anyone does have any questions, but I can also provide an email address if anybody wants to have a chat with me outside of this. So thank you, Katie and Emma.
Thanks, Amber. That's really, really helpful. And now we will hand over to Rowan. The floor is yours.
Hi, hello. Apologies, I haven't done any slides. Sometimes I'm better when I just talk, I think. So my background is I spent the last 20 years as a social worker in Plymouth working with people with drug and alcohol problems. I'm also co-lead of Devon Maternity and Neonatal Voices Partnership, doing service user involvement, working with the maternity system to embed service user voice into service design. I currently work on the Pathfinder currently work on the Pathfinder project, which is around sexual violence. I'm a specialist change lead there. And I'm also working for Devon Mental Health Alliance 1 day a week on their trusted assessment work. And I'm just really interested in how we can land this, how we can embed this in the system, because I think in all the work I've done over my career, in everything, all the pies I've got my fingers in, I just feel like this could fit. It could just make a massive difference to people. It provides us with a real, we talk a lot about how it's not just about the tool, it's around the change. But I think this is the tool that could facilitate a lot of this change. Everything I've done, people fundamentally, all the kind of feedback we've seen, all the stuff we know is that people just want to be seen, heard and understood. There's a lot of duplication in the system. There's a lot of wastage. Everything is very kind of deficit based often. Are you in, are you out? It's about managing scant resources. It's about criterias and waiting lists and all those kind of things. People often say to me, I'm not severe enough here, but I'm too complex over there. Where do we go? People are kind of getting labelled. And I think trauma and trust play a huge part for everyone involved in systems, not just people trying accessing systems, but for people working in them, for practitioners as well. The repetition is really hard. There's a lot of vicarious trauma. There's a lot of burnout amongst staff as well. And I think we really need to acknowledge that. But on the flip side, there's a lot of positive stuff. There's a lot of change coming. There's the kind of local government review, the community mental health framework and the personalised care framework fits very well with this kind of approach. The no wrong door, the trauma-informed practice, the holistic whole person approach, and actually that move towards formulation. Your story just fits with all of this. As part of the Pathfinder thing, we're looking again at a whole system approach to sexual violence. We're looking at embedding trauma resilience hubs in Devon and Cornwall. There's a big piece of work around training, trauma stabilisation training, and we're looking at one trusted assessment. Workers have said, previous to this, I was working on a project around mental health and rough sleeping, and just the journeys through people's system. Someone wants to access something. Yes, that's great. You need to do that, but you need to go back to the person, take them to GP. GP needs to do a referral and move it forward. It's just not helpful, and it's not the person's words. So the work I'm doing around trusted assessments is really interesting, and it's tricky. The term trusted assessments, for me, trusted is, are you worthy? Do I believe you? And assessment is about judgment. As part of the mental health and rough sleepers work I did, there was I think there's positive stuff for trusted assessment in terms of avoiding duplication and all that kind of stuff. As part of the mental health and rough sleepers work, we were able to remove the need for that GP referral. And actually there was a real kind of commitment from this project to formulation as that approach, that kind of more therapeutic way of seeing things. What's happened to you? What's important to you? What do you need now? What sense are you making about this? For me, the trusted assessments and all of this stuff is about the person's voice. It's about co-production, but also, as we've touched upon in across all of this, it's about best value and it's about that culture change. And this is a really good vehicle, I think, for delivering that. In some of the core mental health team SOPs, trusted assessments is part of that. You know, we're looking at kind of, there's conversations going on about one assessment across mental health. Where it's kind of stalled, where it stalls is around engagement, is around service user voice and co-production. This is rooted in that. This is coming out of that. And there's also the information governance thing. And I think there are solutions here as well. It's your story. It's your words. If I go to the GP, if I go to someone and I tell them what's happened to me, it's recorded in their viewpoint. And then it's read by someone through that lens. And then it's put into an assessment form to go off to someone in their words. So from information governance perspective, if it's the person's words, you can't argue with that. There's got to be ways around this kind of stuff. So again, I'm hopeful about that. So I get really focused on how can we land this with other stuff. You know, Change of Futures, there's been an extension in their funding, but it's only 12 months. These things are more powerful if they're embedded in other bits of work. I'm working very hard. I think this is a solution for us in the sexual violence world. In Plymouth, we have the team around me approach, which is great. Look it up. It's really strengths-based, really kind of collaborative. And what we want is people's voices in everything. No conversation about me without me. And again, this is a way of doing that. We don't want another panel. We don't necessarily want another referral form. What we need is the person's words. And I think your story can be the way of that. We need to acknowledge that actually sometimes those meetings don't feel safe for practitioners, let alone people trying to use services. And I think your story gives a really good way of doing that, a really, really kind of good way of getting that voice in there. The community mental health framework, they're always kind of moving towards this thing. You know, I had a conversation like, well, we've got RECWOL 10, we've got dialogue, we're asking these kind of questions, but they're quite tick boxy. And actually, if you're anxious, here is the information. I don't want to have to talk about this. I don't want to be re-traumatized. You know, it's about addressing that power and giving people more control. It's good, but it's not quite enough yet. I'm also a massive fan of power threat meaning framework, and I think this really supports that. If you're not aware of it, go and have a look. It's coming. You know, it's an alternative way of making sense to what's happened to you without putting it separate to diagnostic models. Fits with trauma informed. There's a real kind of package being put in place. We're seeing it as a kind of whole system approach around trauma informed practice. There's trauma informed practice for training for staff in Plymouth. We're looking at putting this trauma stabilisation. This is what's happened to you. Now what? What support do you need to kind of deal with it? What support do you need to manage it? It might be therapy, it might not be therapy, your choice. You know, what do you need? And also what we know is there's some amazing work going on in the system. You know, people go where they feel seen, heard and understood. It's not necessarily professionals, big services, organisations where you have to be assessed and eligibility criteria where the work is happening. So this could be a way of, you do it yourself, you do it with a trusted professional, a trusted practitioner, and then it informs that next part in your journey without that repetition, without all of those duplications, that power dynamic that I'm going to have to tell it again. Yes, there's power in telling your story again. I understand my story every time I tell it, but I don't want to have to keep telling it. And I want to be mindful of who I'm telling it to and how it's told, not in the form of a tick box. I love the bit that says, you know, how are you sleeping? You know, it's that whole person approach. You can say, oh yes, this is a whole person approach, but that doesn't apply to you. It's got to be your words, isn't it? So yeah, it's part of the training, more receptive as a system. This is the kind of it's about the change rather than a tool. I say a lot, this is not about kind of changing the headlines of what we do. This is about that sustainable change. But it's got to be deeds, not words as well. You know, this is co-produced, it's data sharing. This could literally fit in everything. It could fit in maternity, it could fit with rough sleepers, it could be translated into different languages. I just think it's really powerful, really, really powerful. And I think consistency is key. We want to get this in as many places as we can. There's been lots of different passport things up and down the country, which are great. And we need to have that flexibility for what works for people, but it's about create in that common language as well. This is therapeutic. We know this stuff. It's a work in progress. It's your words, you give consent, but there's real ownership from here. And we're really excited about what a difference this can make across the system. And we're so impressed with the work that Katie and Emma have done. And we're so grateful for the amount of time and resources and how co-produced this has been. And I feel like it's my duty to kind of be that kind of conduit and share it where it needs to go. We really believe in it as an approach. So thank you for the work you've done. And we've got loads of questions. Hopefully we've answered some of them. And Katie and Emma, over to you. How do you want to go through those questions? I've been scribbling down.
Yeah, thank you so much, Rowan.
Thank you. That's absolutely amazing, and thank you for your kind words. I am just gonna go back and share the question slide, and we can start going through the chat. Or do people want to put their hands up if they have any questions?
I've written down all the ones from the chat if we wanted to start with those ones. So Molly asked a few at the beginning. Which customers or clients were consulted? So we had, in the co-production groups, we had 15 people. They were from a range of organisations. They'd previously used housing, drug and alcohol, someone from using Trevi. There was a range, but we can share those focus group findings if you like, Molly.
The other thing we're going to be doing as part of launching this is we're taking it to the co-production leads of DPT, Devon Mental Health Alliance, and Live Well. So anything that we do, that's the bit where it's kind of sort of is that engagement. So we can share this. There are mechanisms, and we want it. You know, we'll keep checking. We want to keep checking out where this goes.
Thanks, Rowan. I can see some questions from Molly. How can this form be utilised for rough sleepers who don't have access to computers or phones? Well, if there's a person out doing outreach and they have their own link or their own access to their own story, they can complete it with people there and then. You said appreciate they can go to Shekinah, but not all will. Can people complete at PCC? Yes, we are working, well, not yet, but we are working with the hub redesigning to see where within the kind of process we can include the completion of the passport. Julia, some questions from Julia. If you do have any questions, feel free to put your hand up, and if not, we'll just go ahead and answer some questions from the chat. Go on, Katie. I think you're on mute.
Thank you so much. Oh, I'm on. Can you hear me now?
Yeah.
Oh, perfect. Thank you so much for such an inspiring discussion. I'm a psychologist in the autism assessment team. I think we've reached out a couple of times, but I've never been able to get to one of the meetings. So I'm really glad that I could be here today. So it really, really aligns with what we're doing in the autism service at the moment, because we have designed an app which we're piloting at the moment to collect people's self-report of their experiences beforehand, then meeting with the person. So that's a lot more needs-based, like autism or not, what does that person need? So then we can really tailor the recommendations and create more conversation, exactly what you've just saying. So it's a more positive, trauma-informed experience. So I think it'd be really good to link in with you guys to work together. We're researching it at the moment. We've used Visiba, which Live Well commissions, and that's what they use in their GP practices. So we've created an app. So yeah, exciting to link in, and I think this is the way forward. And I think you've given a lot of words to what we've been thinking and why we've gone this way with how we're doing assessments. So not really a question, just
I think
it'd be good to
link in. I think it can link in. I think there's loads of people doing excellent work. If we can get some, combine the kind of questions, Live Well are doing some other, I think DPT as well are using the Sensio app, and there's going to be questions on there. these are questions that have been co-produced with people. It makes sense to kind of do this. Here's a really good, strong evidence base for this. And also this is needs-led rather than system-led.
Yes. Yeah.
Isn't it? It's just the kind of fundamental thing we're looking at. So that's really exciting. So thank you.
That's amazing. Thank you. And before we move over to Claire, I'm just going to answer another question from the chat. Julia said, how long will the pilot run for? Well, there is no end date at the moment. It's an ongoing process of testing and learning. We are trialing it with individual people at the moment. We hope that by springtime, we'll be trialing it with the organisations. What else? If the project isn't funded, what happens to the information previously entered by people? Will they still be able to use the tool? Well, once they've completed their story, they will receive an email with their completed story. So yes, they will still have access to their story. And whether the what entered
Will
by
you still be
people.
able to use the tool?
So it depends. If there are organisations that are trialling the tool or using the tool within the organisation, then yes, they will be able. Which agencies are using the tool at the moment? It's just Plymouth City Council at the moment. We are trialling it and testing it. Is it helpful? Is it useful for people outside of Plymouth? It can be. Just depends on how you use it. But yes, absolutely. And another question
There was a
from
question, Vicky, yes.
Will there be support available for those who are unable to read, like an audio version, and for those whose first language is not English, also a storage change in time, who will be able to ensure this is updated appropriately? So really interesting point, because actually one of our participants was visually impaired, so we were able to use the Immensive Reader to kind of read the questions out loud. So yes, there is an option to read all the questions for the Microsoft Forms to read all the questions for you, and there's also an option to automatically translate it as well. As stories change in time, who will be able to ensure this is updated appropriately? Again, as we talk about empowering people to take control of their information, if there is a change in circumstances, the person can contact their support worker to update the information, or they can update it themselves. So we will hand over to Claire now. Claire, what's your question?
Hello. So I work for Community Connections, and I work primarily with the rough sleepers. So as you can imagine, we've got a lot of traumatized people rough sleeping. One of the issues that we find is that while we work in a trauma-informed way, is that we can't necessarily prevent them from rough sleeping. So how would this help them? How would this so they tell their story, but then they still have to kind of rough sleep, if that makes sense.
This is not a fix-all. It's part of system change. And actually, I think it's something about setting that tone in the system. If it's a different way of getting information out of people and sharing it, but we can't change the legislation. We can't change the law. Some people might choose to sleep out, or they don't fit that kind of criteria. I still think it's a positive thing. It's better than going, tell me all your story. Oh, computer says no. That day, you have a huge amount of pressure on you in community connections. We all do. Sometimes we can't act in a way that we would like to, or, we're not able to. There's no legal framework for us to do it. But I think it's about how we capture and hold information and how we do it in a more kind of respectful way. So we're not asking, tell me everything, tell me all your deepest, darkest secrets. I'm not going to tell you where it's shared. Yeah, I don't care that you haven't told, that you've told someone else. Tell me all of that, and I'm still going to say no. It's about being respectful about how we do it, I think, and starting those conversations. One day we're going to change society is my big dream. I think this is one of those kind of steps in it. And it's, for me, it's bigger than its parts. It's about the respectful nature of it. It's not tick boxes, and it's our words, it's your words, it's their words. And it's, even if we just start off that conversation, that even the fact that we're having the conversation about consent and how we share things and how long things are kept on the system, and the fact that things change over time and who interprets it and what we're doing with the data, I think is a good thing. So it's not a fix all, but we think it's a good step towards the right thing, because you can't change the law yet.
No. Thank
Yeah.
you.
And also, but it might save some money. It might save some money across the system and stop that duplication and stop the kind of activation, escalation. I've bloody told you this. I told Harbour this the other day. Don't you know this? This is on my notes. You know, why are you asking me again?
Thank
So
you.
we're hoping it could be helpful with that.
Thank you.
Yeah.
Thanks, Rowan.
Thank you. Going back to the chat, I can see some more questions. I can see a very interesting comment from Molly. How will this form stop duplication and change internal processes? Not being negative, I love the form, but I think it's ambitious to think it will prevent people from being pushed from pillar to post, as that issue is within services, not in the way we gather information. Yes, Molly, absolutely. It's very ambitious, and you're right. The form is not going to change it. The tool is just a tool to kind of help people along this journey, to stop the re-traumatisation, to stop people having to repeat themselves. What's going to help change that is our behavior and how we deal with assessments as practitioners. So it might be that somebody's coming in for an assessment, they've completed their story, and you might need to consult somebody from drug and alcohol services. Instead of referring them, you could say, could I share your story with drug and alcohol services, and they can maybe give me a little bit of advice on what to tell you. So just how we act within these situations is going to change. The form itself is going to be useless if people don't use it in the right way. Sorry, Rowan, you wanted to say?
I'm terrible for this. I get so excited about it. It's terrible. But there's a lot of different meetings that happen. You know, we have strategy meetings, we have risk management meetings, we're going to have team around me meetings, there's the primary care multi-agency team meetings, there's creative solutions, and that's just in Plymouth, and there's probably loads more that we're talking about. And often they're focused on what's been done, and they're focused on eligibility and diagnosis. And the bit that gets missed sometimes is the person. What's important to them. I've sat there and thought, well, clearly this person needs therapy. That would be the kind of thing based on their trauma, but they might think something completely different. So it's not going to, maybe that's the change. Maybe that's the things. It's not going to stop that pillar to post, but hopefully it's a mechanism of putting the person in those spaces in a way that what matters to them, not just what matters to the organisation. Does that make sense? Molly, you've got your hand up. Do you want to come in for a convo?
Yeah, you're right. Thanks, guys. I've got kind of a few things to unpick. So the form in itself, the form's great, and I think if it was used in the right way, it is going to be helpful. I guess my reluctance comes from, so I manage George House. I know that none of my customers have been consulted about this form, and I think that sometimes we need to look at the people that have, and I'm not slating the form, Katie. I love changing futures. I don't want to get in any trouble, just disclaimer. But I just think sometimes the people that are going to be using this form the most are the ones that haven't been consulted. And actually, for me, trying to get one of my customers at George House to fill out a 40-question document is going to be tricky, and it's going to be tough. And I think that, Rowan, you said earlier about how sometimes we often say, tell me your story, but still the computer says no. Well, actually, that's still going to happen, isn't it? Because we're going to ask people, tell us your story. The computer will still say no.
It is, but we're doing it once, and we're doing it in a more trauma-informed way. And actually, I think this is a version 1. And as a version 1, I think it's good. There could be something that actually we could start changing our forms in other areas of the system. So it is 4 questions. What's happened to you? How does it affect you now? What help do you need, and what do you need, and what do we need to know about you before? And it might not even be the person filling out that form. I think I mentioned about trusted practitioners. You guys know these people, you work with them 24/7. There's all that information we have about people, about their hopes, their dreams, their aspirations, who they get on with, what's important to them, what dogs they like. These are the things that make change for people and make them feel seen and heard, that whole holistic bit for them. And actually, maybe as workers, we can say, when we go into meetings, we're taking their story with them that we've co-produced with them. They might not sit down, but actually as a worker, there's plenty of people I could say, I know what's happened to them. I know how it affects them now. they're telling me what they need, and actually I know that if I want to see them, I have to go to Shekinah at 8 o'clock in the morning, 5 days in a row, and maybe one day I'll see them for 10 minutes. And it's about building up that trust. So I think it's almost for us as workers in the system too, it's in its pure form, it could be 40 questions and it can be the 4 questions, and we want it filled out by people, but I think it's about more than the form as well. So I totally get it. And actually, that the poster was put out to people, no one responded to it. Maybe the next stage of review and co-production is we use the peer researchers or something to go and run it past, do a drop-in session in the George. And actually we're looking at, I'm looking at with Devon Mental Health Alliance, looking at doing something similar in Ilfracombe in a community space up there. We're talking with the high intensity users, in all of these spaces. It needs to be kind of checked out with people. We're starting to we're thinking about using this. What do you think? Rather than, right, we're doing community mental health framework now. We're going to ask you re-qual dialogue and we want your story in the risk assessment. That's fine. It's the culture change towards what's important to you. What do you think? And I totally take your point. Totally take your point. It's about how do we capture those voices too.
Thank you. Sorry. So just on that, is this form being used in place then? So if a customer or client, I know we all call them different things, so a customer wants to make a housing application, I don't know, I just want to understand it right. So they go to the council, are they using this instead of the standard assessment that they do at the council, or is it optional? Is it?
So at the moment, we have individual people trialing the tool. So the people that are trialing the tool, they took part in our focus groups, and what they're doing is kind of on a one-off. If they are engaging with the GP or with anybody else, they will actively share it with people before their assessments. So it is optional at the moment. Jess, I'm not sure if you wanted to come in.
Thanks, Katie.
Yeah, sure. Thanks for that question, Molly. I thought I'd just jump in. So, in our ideal dream world, in the future, people will be able to complete this and will be able to use it as part of that CCO assessment. Okay, it doesn't answer all of our questions, but it would give the CCO, the housing officer, an idea before they were doing their assessment for that person, and it might it gives them more knowledge, more background, more context. Like you said, because we operate under legislation, there are some questions that we have to ask, but it means that questions can be framed differently. They can be like, I have your story in front of me. I can see this says this. Have I interpreted? Have I understood this correctly? Is this what happened? Rather than asking that person to try and tell it again in their own words, and depending on what's happened to them that day, they may be more or less articulate. So that housing officer has it in front of them. Moving forward, what we'd also really like to do is use it more within the hub process, Molly, as part of that move on. So you've got a client in the George accommodation, they've been sustaining that accommodation for the last 12 months. They've been doing really well. You think actually they'd be better in lower level support. They're evidencing that. We can use that story to send to another provider to look at that, to provide evidence, because it's strengths based, on why they're ready to move on, why they're ready to go into that lower level support, and encourage that flow through the system and give people more independence and more choice back. Does that help?
Yeah, thank you.
Thank you. I'm really conscious of time. We're running 1 minute over. Emma, did you want to say anything else?
Yeah, I was just going back to a question previously, but I think because it's quite easy to get really confused of how it will work in practice, and I think details of how it will work best will emerge when it's being piloted within teams as well as individuals. And there's many options for how it can be implemented. Like we touched on before, like it could either solely replace an assessment or it could support an assessment. And I think what the dream would be is if teams could just accept it. If someone did come with their story, it could be accepted as a way of supporting an assessment. So it doesn't need to be like everyone, it doesn't need to be replaced by everyone, but it can work in practice in many different ways.
Thanks, Emma. Right, thank you everyone so much for attending today. We've had lots of interesting questions, and we're again really pleased with the turnout. If you do have any questions after, we will stay on the call for a few more minutes, but we will send out all the information and resources later. So thank you everyone.
Thank you so much, everyone. Really appreciate
Katie,
it.
thanks, Emma. And thanks,
Thanks,
Rowan.
bye.
Bye.
And I will stop recording now.
I'll go through the whole chat afterwards.